So our colleagues from India have also joined, which is
Okay.
fantastic.
How many people are there, Alok?
So at the moment, we've got 11 from India,
Yeah.
9 other participants, a total of 20.
Okay.
Yeah. Just got a few who are trying to get in,
Okay.
struggling with the link. I'm just going to give them a hand, but we'll start in 2 minutes, Lisa.
You want me to open my presentation?
Yep, go for it. Yep.
Can you see that?
Yes.
Yes. Yep.
Great.
Fantastic. So, guys, could I just ask you all to mute yourselves if you already haven't? I'm going to make a start today. My name is Dr. Sharma, and I am a neonatal consultant working in Southampton. And I would like to introduce to you Lisa Leppard, who is one of the senior sisters who's worked on the neonatal unit in Southampton and has led the family care team for the last 35 years. She has now taken up a job with the neonatal network in Wessex and Thames Valley, where she's lead care coordinator who will be looking after neonatal palliative care and will be training as well as implementing changes, obviously, uh, a lot of positive influences to try and see if we can make palliative care better. But today, what she is going to talk to us about is the process of communicating and how we have conversations with babies at limits of viability, in particular when we're talking about end of life care or potentially when we're having a difficult conversation with regards to prognosis. I think the important thing from our perspective is trying to observe and see and learn about different communication styles in different cultures. And I couldn't think of anybody better than Lisa Leppard. So without further delay, I'm going to hand the floor over to Lisa, mute myself. Go ahead, Lisa.
Thank you, Alok. That's a very grand introduction, so I hope I do that justice. And just so that you sort of just run through why we're sort of talking today, what I'd like to really go through is how we begin those conversations with parents around end of life care. Some of the things that perhaps we can say, perhaps some of the things that we perhaps shouldn't say, just perhaps how to phrase things in a gentle but informative way for parents. So what we'll do is go through some slides. I think I'm going to talk for about sort of 45 minutes and Alok is going to take any questions from you. So I hope my voice doesn't get too drony for 45 minutes because I'm used to interacting with people, so this is a new thing for me, so I hope it goes well. But as I say, if you have any questions, Alok will take them from you and then we can answer them at the end. I hope that's okay. So I thought probably what we'd first look at is what some of the barriers are really to us having conversations with parents and initiating those difficult conversations with parents, perhaps when treatment, we're at the limits of the treatment that we're able to offer their babies, and what actually prevents us from having those conversations with them. I think it's a huge clinical responsibility for all of us, and especially the lead clinicians, to come to the conclusion that there is no more treatment that that we can offer. And I think sometimes as intensivists we find that very, very difficult, because we have quite a lot of things in our backpack, if you like, that we can offer babies. But sometimes it does come to a point where actually there are things that we perhaps could offer, but is that right for this particular baby? And coming to those decisions as a team and with the family are incredibly difficult. So it's a huge clinical responsibility. And I think one of the responsibilities that we have is not to do everything. Just because we can, it doesn't mean we should. Even if there are small chances, I think sometimes we have to think about the overall picture for that child, and the overall picture for that child's well-being going forward, and what we hope for that child in the future. And obviously we have to keep the child and the baby central to any decision-making process we make. Obviously we make that with the family, and I'll go on to that a little bit more later on. But I think it's really very important that the baby is kept at the centre of our thoughts and our management and treatment processes. I think we do worry if you're going to tell a family that their baby is going to die. What if I'm wrong? What if I'm making the wrong decision? I think what's really important as a professionals is that we always have these as team meetings. This is never a decision that is made by one lead clinician or a clinician or a nurse on their own. When we're moving to end-of-life care for a baby, we will always have had multiple discussions. And that's why I think it's really important to have effective communication with each other as a team, but also with the family throughout their stay with us. And again, we'll come back to that a little bit more. So hopefully those thoughts of what if I am wrong, you will have discussed with your colleagues, so you will feel confident that these are the right decision making. And as I said, it's never going to come down to one person to make those decisions. It's an incredibly difficult thing to do. It's an emotional burden for the team and for the family, because we work very closely with the families that we care for. So none of these decisions are ever taken lightly and without a lot of thought. I think as medics we also have a sense of failure. I think it's hard sometimes, isn't it? Like you'll hear your colleagues say, that was a failed resuscitation. You've never failed a resuscitation. It may have been unsuccessful, but as a team you will have done your absolute very best for the baby in your care. So I think sometimes it's changing the terminology and changing the words that you use within your team. So you haven't failed, you've been unsuccessful at this point, but you have tried your absolute best. But I think as clinicians and nursing staff as well, we'll always question, have we done the right things and have we done them well enough? And sometimes we do have to come to an opinion, and that's why we work as a team, that actually we have done the best we can. We've gone through all the available treatment options. We've watched this little person struggling, and actually now this is the time to reorientate care. We always want to retain hope. There is always hope, but sometimes it's about reframing what hope looks like. So I think with a family, when we're moving towards end-of-life care, it's about reframing hope. What does hope look like? So all parents will hope that their children will grow up and they will have fulfilled lives and they will have successful lives. But then sometimes when we're working with families where we know that moving to end-of-life care is the best treatment option for that baby, we can retain the hope of the family that we can ensure that their baby and they have a pain-free, meaningful death, and that those parents are involved throughout with all of that decision making, and that they're able to spend as much time with their baby as possible to create memories in the short space of time that they have. So I think retaining hope is, we always do that, but sometimes it's about reframing what hope looks like. I hope that makes sense. Telling babies that they're telling parents that their babies are going to die is hard, but the one thing that's harder is not telling them. And I think that's why it's really important that we are open and we are honest with families from the word go, from the moment we meet them. You know, that may be that we meet them in the antenatal period, so before their babies are born, and we're very open and honest about what the survival may be of their baby, what their baby's treatment may look like, what being intensive care might be like for them and for their baby. But the one thing that's harder is not telling them at all. I think if to give false hope or not tell them that that their child or their baby may die is not being open and honest, and actually by doing that we are not supporting the families in the best way possible. I think you're actually keeping things from them, so that actually when you do then need to go on to have a discussion with the family about perhaps the treatment that you're offering is not working, and that you are looking to work towards moving towards comfort care, that it comes as a huge shock because they have never had that conversation or had any parts of those conversations. So I think that is really, really important. That'd be the one thing I would always say to you, is you are doing a family no favours at all by not being open and honest with them, and not telling families what the thought process of the team is. Because I think if the team is thinking it, the family must be aware of it. Who decides? Best interest. This is I guess in the UK, and you'll know from your own countries what terminology you use, but best interest is used a lot. I think sometimes when we meet families, we talk about what's in the baby's best interests. And I think we have to be very, very careful with using best interests as terminology. And I think very much within palliative care in the UK, we're trying to move away from that term best interests, because actually the only people that can decide who is best interest and is the court of law. And best interest is a legal terminology. So sometimes when you use the terminology best interest, that can create anxiety with family, and it can create some hostility, because as a family, families will believe that they are in the best position, they have the best interest of their baby at heart. Who are you as clinicians or nurses to tell me what's in the best interest for my baby? So I think if we can move away from using best interests and perhaps use the terminology of best treatment options, and you can say to a parent, the best treatment option for your baby after you've had these conversations with them is to move to comfort care, palliative care, end of life care. There's lots and lots of different terminology within the palliative care world, and I guess you will know what you would be used to saying. What I would urge you not to say is withdrawal of care. Palliative care is not withdrawal of care. It's redirection of care. So we're moving away from active treatment to comfort care, palliative care, end of life care, but we are never ever withdrawing care. And I think that is really important, because I think again, if you don't use the terminology withdraw care, then parents will be less anxious, because it may well be that some parents could interpret that you're going to just take the baby off a ventilator and leave this baby to die somewhere, and that is not what we're talking about. Palliative care, end of life care, comfort care is intensive care right to the very end, and we would give that baby the same level of care and attention that we would do if we were looking after a baby receiving full intensive care. It's just the orientation of care, the direction of care changes. So I hope that makes sense. And I've, on this slide you can see a judge, a doctor, baby. Maybe if you ask, if we could ask a baby, they might have very different ideas about what their best interests are. The nurses working alongside the baby and the family may have very different opinions of what best interests are. So I think if we work as a team, we talk about the best treatment options for the baby, and certainly present best treatment options to the family as a united front as well, which is really, really important. In the UK, and you may well have seen this because Alok has told me that there's lots of people joining from lots of different places today, which is fantastic, is the Archives of Diseases in Childhood, and that is a really useful document produced by BMJ and the RCPCH in the UK, which is the Royal College of Paediatrics and Child Health, and this was, I think this probably came out a couple of years ago now. And it's around making decisions to limiting the treatment in life and life-threatening conditions in children. So it's a framework of practice. So I think I'm not going to go into it now because it's a big document, and I think it's something that if you're interested in, please have a look at, because it clearly lays down a framework for good practice when moving to end-of-life care. And as I say, I would just urge you to have a look, but I'm not going to go through it now because it will take too long. Communication. I'm sure in which, wherever you are in the world and whatever your first language is in the world, communication is the basis for all of the decision and all of the conversations we have around parents, with parents. And I think relationships with families and parents and the greater family usually break down because of poor or ineffective communication. So be very clear in your communication about what you're talking to families about. We'll talk about the Spikes formula, and I think Dr. Sharma has sent some of you the Spikes formula, and you will have seen that, and I will refer to it a little bit later on. And if you haven't, I'm sure it's available after the presentation, and Dr. Sharma will perhaps talk about that slightly at the end. But that's just a formulary for preparation to actually having conversations with parents when you're giving them difficult information or when you're delivering end-of-life care. But I will come back to that later. So effective communication is absolutely key, and I think what's key is that you, within the Spikes, and we'll come back to it, but what you say and what is heard can sometimes be very, very different. So it's really important that we use non-medical as medical terminology as possible, and use information that is easily understood by parents. So what's important when you have these conversations and you're moving to end-of-life care is that you check back with your parents consistently about what they've interpreted by what you have said, because I think sometimes you'll be very surprised by what they've taken on board and what you think you may have said. So it's very, very important that you make sure that what you say is clear. And I think, again, that's why working as a team, you always have someone there to support your families. And I know it's very difficult at the moment with COVID and restrictions, but certainly a nurse looking after the family, or a nurse who's been involved with the family, to be present at those conversations that you have is without doubt one of the most useful tools and effective tools that you can have, because she is another pair of ears that can hear what you've said, and then perhaps after the conversation sit with the family again and ask them again if they have any questions. So always, never have these conversations in isolation, always have them with support for the parents, but also that support is for you, so that you know that what you have been said has been heard by an independent person, and that is vitally important. continuity of information giving is absolutely key. I think building an expert to expert relationship with your parents is absolutely key. Seek your parents' views of their baby. They are working in partnership with you. They generally, obviously, there will be differences within the countries that obviously I'm talking to today as to what your parents' the expectations of your parents are, but your parents will become the experts in their child because they will spend the vast majority of time with that child consistently. So they are the constant in their baby's lives. So use them. Ask them on a ward round, how do you feel your baby is today? Have you noticed any difference? And I think if that relationship is built from the word go, then you're less likely to have breakdown in communication with your families if treatment doesn't work in the way that you had hoped and the baby's prognosis becomes poor, and that you then are going to move on to moving to comfort care or palliative care. And I think if you've had effective communication and good continuity of conversation throughout, then that conversation about moving to end-of-life care should never, ever, ever come as a surprise to families. It should never be a surprise unless you have obviously had a sudden acute deterioration in a baby's condition. That's different. But if you're having a planned move towards moving to end-of-life care, that should never, ever come as a surprise to parents. So I think regular updates on progress is really important. Honesty and sharing concerns regarding the baby's prognosis is really important. If you have concerns about that baby, it's important that you share those with the family, not right at the very end, but as they are actually happening. So it may well be that you have concerns, but you're not that concerned that the baby may pass away or die at this time. However, it's important that the parents know there are concerns and that this may change the onward prognosis and progress of their baby. It's really, really important. It's really important to build that relationship with the bedside nurse. The bedside nurses that you work with are absolutely imperative. As we work as a team, so as a medical team, you will see the family on a day-to-day basis generally, maybe not on a day-to-day basis, but your nursing team will probably spend the vast majority of the time with that family. So really rely on your nursing staff. They can advocate for that family. And it may be that they will share something with the bedside nurse that they may not share with the medical team. The parents may want it heard, but they may not feel in a position to be able to say it. So I think it's really imperative that you encourage your nurses to build that relationship with the parents at the bedside. As I said before, with parents, they are the constant in their baby's care. They are going to notice if a baby has become unwell. They're going to notice if their baby's skin colour changes, if they look like they're working harder. Those things are really, really important. And plus, that empowers parents to feel part of their baby's care. Care in partnership is really important. And certainly within my new role, which Alok was telling you about, that is something that we're going to be working very hard with that actually we work in partnership. We care for their baby as partners. It's a collaboration of care rather than dictated by the medical team. We work together and we work in harmony together. We've talked about advocation. So yes, again, those nursing staff can advocate for the parents, which is really important because the parent voice is really important. We need to know what their thoughts are. We need to know what they're thinking. Sometimes parents will have got to a point before we do where they wonder where we're going with their baby's care, if their babies are going to survive. But quite often it's very difficult for them to actually raise that, and they will wait for staff to raise that with them. But again, that's a conversation a nurse can perhaps sometimes broach with the team at the bedside. Nursing staff, I'm going to be an advocate for this. If you're having multidisciplinary team meetings regarding the ongoing care of a baby or changes in treatment direction for a baby, you must have the nursing staff involved. This cannot be done in isolation with medical teams. You must speak to your nursing team for the very reasons that I've already spelt out, is that they may well have things that they can share with you that the parents have shared with them that they haven't wanted to share with you in directly. Burdens versus benefits with continuing active intensive care. Again, burdens and benefits I think is a very difficult terminology to use with parents. I think you have to think of a softer way to have that discussion with them. Again, burdens and benefits in UK is definitely used by the judge in a court of law. If he's called to a case where there has been a breakdown of relationship between parents and caregivers and professionals about the right direction of care for a baby, he will have a checklist where he will go through what is seen as a burden of care for that baby and what is seen as a benefit. And if the burden outweighs the benefits, then he would then decide that actually it would be best to move to comfort care for that child. And would agree with the medical team if that's where they were coming from. So I think if you're going to talk about burdens and benefits with parents, within your own language, think of a softer way to put that. What treatment is going to give your baby the best possible chance? It may well be that what we're going to do is going to be so painful and so intrusive to that baby that's not right for that little person. And I think you can use that kind of terminology. Intensive care is painful. Parents understand that intensive care is not nice. But intensive care being not nice is acceptable if there is a positive prognosis going forward. But if that's not going to be the situation, then it's really important that we have that conversation with parents. So perhaps just think about burdens and benefits of intensive care and just think about how you might like to word that yourselves. And as I've said, if we're having any of the above, those kinds of thoughts, conversations, and those conversations are happening well and they're happening with consistency and continuity, then parents are going to be far more likely to be prepared for end-of-life care and for treatment, intensive life-sustaining treatment, to be withdrawn. If possible, and I don't know your work settings, but it's with babies, if it's at all possible, it's good to have a lead clinician. So it's important that you have a consistent information giver, so that the information that parents are receiving is delivered in the same way each time that they perhaps have these conversations, these in-depth conversations, because they will be having conversations with medical and nursing teams at the bedside on a daily basis. But I think it's really important that they have these conversations with a lead clinician who can bring all of the information together and deliver it in the same way each time. And that, again, that person will know that family, that person will know how that family best receives information, and sometimes what level of information those families are needing, because all families are very, very different, as I'm sure you're aware. I don't need to tell you that. I think when you're meeting with a family, I have that, like this little hand, it's about 5 cardinal questions. When you meet with them, and we'll go through this with Spikes in a little while, but tell me about your baby. Let the family tell you what they know about their baby, rather than you going in and saying, right, this is where we are, this is what we're going to do. It's much better to go in with a softer, tell me about your baby. Tell me about your understanding of their condition. Tell me about what you know. What are your hopes for your baby? What are your fears for your baby? Where do you get your strength from? This gives you a really lovely basis to start your conversation with that family. Then you know where you're starting from and they feel involved in their baby's care. So I think if you can think about these 5 cardinal questions before you deliver any information to the parents, this puts you on a really good footing, because I think if you've already decided what you're going to say before you go in, then you might find that you're at odds. I think if you'll need to know what information it is that you want to convey, but actually once you have an understanding of what they know, that may change the way you convey that information. I like this slide as well. Wish, wonder, worry. Wish is an alignment with people. I wish I had better news for you. I share your You can never know how they're feeling, you can never feel the way they're feeling, but you can share how they're feeling. You can wonder, I wonder if actually, we have got to a point with babies care that actually offering more intensive treatment is not the best treatment option for your baby, is not the best treatment for your baby. The best treatment would be to move to. And then worry gives honesty. You can share that you're actually worried. I'm worried that despite all we've done, then whatever you want to say. I'm worried that time is short. I'm worried that you won't have the time with your baby. I want to be able to give you special precious time with your baby. Your baby is becoming unwell very quickly, and I feel that we should. So I think I like the wish, wonder, worry. Take that with you, because I think that makes you more human. It makes you less authoritarian, and it just brings a softer element to the preparation of the conversation that you're having with the family. Decision making. Facing the decision is very difficult and may be considered a burden. The burden of moving to end of life decision making is shared with the family, so it's shared decision making, but the end decision making process is with the medical team. It is not right that a family is left with the burden of what do you want to do, because of course they want their baby to survive, of course they want their baby to live, so they need to be guided. As I said earlier on, some families may well have got to that point before we have, but some families will need a lot of guidance. Many parents prefer decision making, and actually it makes a difference to how they cope emotionally moving into the future as well. So they're less likely to have regrets and guilt if they feel that this is shared decision making. The burden doesn't lie with them. Some parents may well need guidance from the multidisciplinary team. They'll ask you the what ifs. What if we do this? What if we do that? What happens next? If this happens, how does that work? All of those questions, families will need guidance. No one ever expects to be making end of life decision making for their baby. Children are supposed to bury their parents. Children are supposed to make end of life decision making plans for their parents. The natural way of life is that it shouldn't be this way round. So parents will need guidance. The most critical skill in decision making with families is listening. And I think I've put at the bottom of this slide, the word listen contains the same letters as the word silent. Listen to what they have to say. You do not have to fill the gaps. You do not have to talk all of the time. Listen to what they're actually telling you and answer the questions they have. Don't answer what you think they're asking. Really listen to what they're asking. Drawing out the frame hopes, reframing them, we've talked a little bit about earlier on. Such conversations cannot adequately be managed in a single meeting as well. So I think unless this is a sudden acute deterioration for a baby, where you haven't got the time, this baby will die if you don't, very shortly. When we're planning a move to end of life care with our babies, these conversations may need to be had over several days or several times. I think to expect to convey all of this information and to get an agreement with a family and for a family to fully process the move to end of life care absolutely cannot happen in a single meeting. So they need to be repeated, they need to be explored. Explanation again may be needed. Go back to your cardinal hands. What do you understand by your baby's condition? They will have had time to process. They will have had time to answer more questions. Parents may want a second opinion, which they're absolutely entitled to have if that's what they would like. And I think, as a team, sometimes as a team you feel more supported as well if you have a different clinician come in look at look at the baby's case, look at the baby, look at the care that's been given, and seek a second opinion. So that's not only a positive step for a family, but that's also a very positive step sometime for a team, especially when cases are more difficult. Continuity is key, as I've said before. Consistent contact with the senior team is absolutely vital. If you're going to have these conversations over several days, and you know that you're not going to be here for some of those conversations, then it's really important that you have a key person that you hand over to, and the family are very aware of who that person is, and who they then can go to have continue these conversations, because it isn't all in it. Life isn't like that, is it? Sometimes it will cross over weeks when maybe you're on service week and then it's not your service week, or these things may happen at night and you're on the day. The continuity and consistency is key. So forward planning as to who's going to take over from you, if you're the key person for that family, is absolutely vital to make sure that we do not have breakdowns in communication or things delivered in a different way, and then perhaps a different perspective given to parents, because that's where confusion comes. And again, as a multidisciplinary team, it's important that everybody's voice is heard who's caring for the baby. Any concerns are raised within the team, because what's important for a family is that we present as a united front, that we've had this conversation and that we're all in agreement. But if people are concerned about aspects or elements of the care, or moving to comfort care, that we've allowed them and we've given them the ability to share their concerns with the team as a whole. So coming to an agreement to move to comfort care is about listening, time, further discussion, parents being able to gain further information if that's what they need. Listen again. So when they come back to you again with the further information, or they've spoken to relatives and relatives have then got questions, or friends have got questions, you listen again. Second opinion. If that's what parents have come back and said to you, well, I've read this and actually you haven't offered this, then you can explore that with them, but you can always offer them that second opinion. So hold on to your second opinion. It's a very useful tool for yourselves and the family. Listen again. Can you see the theme here is about listening? It's about listening and hearing. It's not about listening and not hearing, because it's active. Listening is active. You have to hear what's being said. If it comes to a point where you can't come to agreement, then mediation is a very good tool. Bring in an independent person to listen to both sides, and then perhaps bring them together and see if mediation can help you find a common ground and a common way forward that is acceptable for both teams for the care of this little baby. But remember, keeping the baby central to your conversation, not the family. This has to be about what's right for the baby. And then if mediation doesn't work, again, listen, and then you then go for legal support. But legal support should be the very end points of not finding an agreement with a family. Hopefully, if you've gone through all of those elements, then hopefully you won't get to the legal support needed. It does happen, and I'm sure many of us will have been involved where cases have potentially gone to court or been on the way to going to court, and then a way has been found for us to work together and care for the baby in the best possible way. I'll just leave this up for a minute just so that you can have a little read. This came from a paper in 2009 now, but it's really important. A majority of parents wanted active involvement in making life support decisions. Many viewing this as part of their parent obligation. So parents want to be involved in their care. These are their children, they're not our children. So parents want to be involved. Others found that parents find regret and feel burden of decision making about withdrawing medical treatment. So again, this is where we make these decisions as a team, but ultimately the decision must lie with the medical team and not with the parents. So I'm not going to read out the bottom bit, but I'll give you a couple of minutes just to read the extract about the relationship between parents and healthcare providers. that's given you enough time to have a little read of that, and I think that just really pulls together really what we've talked about over the last 40 minutes really. Trust is such an important element in a relationship with families. They do need to trust us, and sometimes, you know, parents have to find trust and have to build trust with us extremely quickly, and you know, we're asking parents to leave their children really with complete and utter strangers and put your complete faith in what we're saying and what we're doing. And in normal life, we wouldn't just go off and leave our children or our babies with people we didn't know and just say, right, bye, see you later. So you know, what we're asking is absolutely huge. You know, the building good, trusting relationships from the minute you meet parents is absolutely imperative. Because if you build that trust, then when perhaps the prognosis for their baby is not good and that their baby is going to die, they will fully be on board because they will have worked with you and you will have worked with them as team baby. So they will feel fully engaged with the care that their baby has had and feel fully informed. So information and choice. So for high quality palliative care for babies and families, informed choice should be offered to families. Explore their thoughts and their wishes and their values. Their values may be very, very different to your values, but it doesn't mean that they're wrong. It just means that that's the value for that family. So it's really important that you explore their thoughts and their wishes. Advanced care planning. I don't know if many of you use advanced care planning, but again, planning is absolutely key sometimes. I know we don't always get the opportunity to do that, but if we do, early planning is key, and that can be done in the antenatal period as well as the postnatal period. So if you have a baby who has a life-limiting condition and may only survive a short time after delivery or may not survive delivery, then you have that conversation with that family antenatally, so they're as fully prepared as possible and that their wishes and values and thoughts are heard again, and that we document those. I don't know how widely advanced care planning is used, but it is used a lot in the UK now. Documentation and communication is absolutely key. Document all of the conversations you've had, because if you don't document it, it has not happened. So document everything, all those conversations you have with families. It's key that that's documented. Perhaps share that documentation with the family, communicate that documentation with the family so they can see what's been written, so that if there is a recourse and somebody says, well, actually I don't remember you saying that, you can go back and actually it's clearly written what you wrote. So I think that's really important. Planning for all eventualities. Sometimes when we move to end of life care, babies don't always pass away. Some babies surprise us and actually survive. So it's really important that you have a parallel plan, and families are aware for some babies that is a possibility, especially big term babies more so. And making sure that good support for parents and families, and identify who take the lead for the family, who will be their point of contact. So it's really important for families that they know that when moving to end of life, who their contact person is, but moreover, once their baby has passed away, who do they contact if they've got questions? Who will be the lead for their family? You know, who do they contact for results? Who do they contact for bereavement follow-up if that's what you offer? So I think it's really important that when your families leave your hospital, that they have a point of contact and they have those contact details. That is absolutely key. And finally, just going back to spikes. So I think, as I said, I think Alok has sent some of you spikes. And you can look it up, but I think it'll make it. He'll talk in a minute, but he'll make it available for you. So spikes is how you can begin a difficult. It's an approach to having a difficult conversation. So the S of spikes. Setting up, make sure that you are in an appropriate setting. These are not conversations that should be had at the bedside. These should be done in private with the appropriate support around you. So privacy is absolutely key. And have that familiar face if you can with families, so that helps their anxiety. Maintain good eye contact, all of those sorts of things. So good communication skills, speak slowly, be prepared to repeat yourself. P is perception. What do the parents know? We've talked about that. That came up in the 5 cardinal questions approach that you can use. Invitation. Invite the family to have a meeting with you. Make sure they know what they're coming for, because there's nothing worse than saying a consultant wants to meet you and then they have no idea what the conversation is going to be about. Hopefully, as we've said before, if you've had good consistent communication, that absolutely should not happen. This should not come as a surprise to families, because that would be very, very unfair. Knowledge. Again, we've looked at that. So I talked to you, didn't I, about checking in with the family. What do they know? Let's go back to your 5 cardinal questions with the hand. Knowledge. Where's your starting point? If you know where your starting point is, then you can build on that and adapt those conversations for every family that you work with. Every family will be different. You may have a way of working which you can take into those families, but you need to have a starting point. You need to be able to adapt your way of working to meet the needs of the family, because this is about the family. This is not about us. Empathy and emotion. So again, there's a useful framework which is naturally NURSE, which is name, understanding, respect and explore. So being able to show empathy and compassion is key. Some will show deep emotion, where others may make no eye contact with you at all, and you can be quite unsure about what response you're getting because they don't actually give you any response. But I think what's important is that you show empathy and compassion to that family, and perhaps normalise their feelings, respect their emotions, offer your support. The way that they may be reacting is absolutely normal for the information that you're giving them. And the S in spikes is, the bottom S is summary and support. So find out if they have any questions, summarise what you've gone through, make sure they're aware that there's the opportunity for them to come back and explore what you've told them again, make sure that they are supported, that there's nursing support, that there are family support, and that palliative care is given at the same level. Reassure them that palliative care is given at the same level as intensive care. And palliative care is about life, however short that life is. And I think that is something to very much hang on to. We think of palliative care as about death, but I like to think of palliative care is about life. It might only be a short life. And again, this is about reframing the hope for the family, the hope that that little life, however short that may be, is a pain-free life. And I think that's something that's really, and as I said, it's not rigid, it's open for adaptation. So everybody will adapt this differently, but I think just having those headings just gives you something to work on in preparation for talking to families. And I think that's probably all I can say in 45 minutes. I probably could go on for a lot longer, but I won't. But I'll hand you back to Alok now, and if you have any questions, I'm more than happy to take them.
So, Lisa, can you hear me?
Yes, I can.
Fantastic. So, thank you so much for giving us that talk. I think what it's beautifully shown us is that having an approach to trying to kind of talk about decisions with regards to end-of-life care, but also kind of decisions which talk about the situation where we might have to approach a difficult conversation, a conversation of prognosis. We do need to have a structure and approach to it. Now, one of the questions that I had is, when we talk about antenatal counseling and limits of viability, often in situations like that, we don't have time to prepare. Do you have any tips on how we manage situations like that? I mean, any idea about, what you think we might be able to, even in the 5 minutes that we have before, be able to try and ensure that we get that conversation right?
I think it's probably going back to your spikes, but limiting it down a little bit more, still using that as your framework if you like. I think it's about exploring from the beginning, exploring what the family knows, what are the family aware of, what are their expectations, what are their hopes. Even if you've only got a very short amount of time, I think that's really, really important, that you get some understanding of where that family is. That is absolutely your starting point, because I think if you don't know where they're coming from, you don't know where to start your conversation, because you could start it on some or with something that they may not even be aware of, and I think then that makes the conversation very difficult. So I think even in the short term, Alok, I would always start with, what do you know?
So just a question from one of the participants from YouTube. Her name is Sheetal and she's from India. So one of the questions that she's asked is that when we kind of counsel parents in India, it's very difficult to kind of involve them in decision making. For some parents, it feels very odd if we ask them to decide on decisions regarding resuscitation of their baby, because the expectation is that it's the doctor who's going to tell us what to do.
Mm-hmm.
Now, obviously, that kind of, it doesn't quite fit in with shared care decision making and giving them choice. And I mean, how do you deal with that? Because some of those parents would kind of think we're putting a burden on them, whereas other parents would want to make that decision.
I think that is a difficult question, Alok, and I think that again it comes down to perhaps what the cultural expectation is of the families that you're potentially working with. And I think I've worked with other clinicians who've come from different countries, where they would say, well, actually the parents wouldn't want to have that discussion with you, and that is down to me. I guess what's important is that the families are informed. I think as long as they have as much information, even if they feel the decision making is with you, shared decision making can be informed consent, can't it? So I think what's really important is that any decision that is made for a baby, even if it's the clinicians that will eventually make that decision, that the shared decision making comes in the fact that the parents are aware of what is going to happen and why that is needed. Because I think even if you don't feel the one that you can make that decision for your baby, you would want to have a full understanding of why that decision was being made. I don't know. I guess it would be interesting to talk. Sorry, I can't remember the name of the lady that you said, but what is her experience of parents? Do parents want to know that level of information, or what is her experience? I don't have that experience, so it would be interesting from my point of view to perhaps understand what that experience is like when a family says it's your decision, it's not ours.
That's really helpful, Lisa. One of the things that sometimes comes up is, one of the approaches we could take is kind of thinking about, like you said, giving them all the information in an honest, transparent, very considered way to make sure that they have an understanding of it, but then making a judgment about whether they feel able to make that decision. And, it's kind of making a judgment about whether that might make them feel guilty, or it might actually be something that is a huge burden for them. And in that situation, we as health professionals and medical professionals might want to lead that discussion subsequent to that by making judgments of, whether they would like us to make that decision for them. What do you think about that? I mean, is that an acceptable approach?
Yeah, I think it is acceptable. I think it's working with your family, isn't it? And and as you've said yourself, there are some families that you would work with where they'd want you to make that decision, but there are other families where they want to be actively involved. So I think what you've said is that's a great approach. I think it's a different way. It's a different way from working that I'm used to. But even I don't think one way of working does not fit all. And I think adaptation is what is absolutely key. You need to adapt to the situation and the family that you have in front of you, and be able to adapt your way of working for that particular family. I think that's key.
So there's just a question from another colleague in the audience. So this is Dr. Nidra from the UAE, and they're asking a question on, obviously, sometimes when we're discussing decisions on resuscitation, especially extremes of prematurity, it might be that those babies are not going to make it, and they're just not in a situation where we think they're going to survive. But the parents want us to do everything at all costs, and we disagree with them. And he kind of says, I struggle with that. How should I approach that?
One of the things that I would explore with parents is, what is everything? What do they mean by everything? Because I don't honestly think sometimes if you actually spoke to a parent of a 22-weeker, for instance, and they say, I want you to do everything for my baby, if you actually told them what everything looked like or potentially looked like, their decision may be very different. Because they don't know, do they? They have no idea. They have no idea what lies ahead of them in the care of a 22-weeker or a 23-weeker or a 24-weeker. So I think what's important is if a parent says, I don't agree with you not doing anything, I want you to do everything. In your conversation, explore what everything means to that family, I think, and then you can have what care you would offer. With an extreme preterm baby, it may well be that you say to the parents, well, we'll see how much your baby can do for itself when it's born, and then you have a limit of perhaps intervention that you would give, because again, it's what's the best treatment for that baby. I think again, it's knocking about interests, because parents at that point would go, well, I know what's best for my baby, you don't know what's best, you've never met this baby. So I think explore what everything is, and then perhaps have a ceiling of care, perhaps discuss with the parents that you will do this, but you wouldn't do that unless they responded in this particular way. And I think that's what's really important. I think as long as parents understand, potentially that if a baby comes out and it shows signs of life, you're not just going to stand there and just look at it, then I think they will be more accepting of that. Even if you were just to give that baby some oxygen, that would be doing something, and it might be that is everything that baby can tolerate at that time. Does that make sense?
Yep. So it's kind of offering them the approach of, and it might be that actually we never stop caring. The baby
Absolutely.
comes out, we try, and obviously the baby might not respond, but actually part of looking after that baby, if it's not going to make it through our efforts, is the fact that we're going to continue to care. We're going to try and keep this baby comfortable, warm.
Yeah.
We're going to keep him in a towel, and we're going to ensure that mum and baby actually are together, that
Yeah.
mum can have skin to skin. It might be that the mum wants to give this baby a little bit of colostrum or breast milk that she might have harvested. There might be some aspects of care that she might want to manage her baby in a certain way if she felt we weren't making it.
Yeah.
So just another question from the audience. So do conversations before and after birth differ? And one of the problems that you face is sometimes if you're resuscitating babies, say at 22, 23 weeks, especially in countries where you normally don't resuscitate them, and you might have parents who want the resuscitation, then is that the wrong thing? I mean, if that's what the parents want.
I think that's a really difficult to say. Is it a wrong thing, isn't it? Really, I think. I don't. That's a tough one, Alok. I think it's difficult to say to give that baby some chance is a wrong thing. And again, it's about life, isn't it? It's about what that life looks like, and it may well be that you say to parents, it's about reframing hope again, isn't it?
Yep.
And it's about palliative care, or care may be palliative care, but palliative care is about life. It's not all about death. So it may be that life will be very, very short, but as you just said previously, it's about perhaps not doing painful interventions. It's about mum and dad being able to hold their baby. It's about mum and dad being able to spend precious moments with their baby, offer baby milk if it's been blistered. I don't think it's ever wrong. I think But I think what would be wrong would be not to be honest about that baby's chances of survival. That is what's really, really important. And certainly with the families that I work with antenatally, where some of those families will have had a life-limiting diagnosis antenatally, trisomy 13, for Patels, for example. I've worked with several families where that's been a case, and they've wanted to continue with their pregnancy, and we have continued with pregnancies, and babies have been born, but the decision, there was already an agreement and discussions around not resuscitating, and that we would keep those babies warm, and that we would give those babies, make sure that that baby had a quality of life no matter what that life length was, if that makes sense. I've also worked with families where they've said, we want to continue a pregnancy, and we've talked about being there at the delivery and seeing what baby does. And then our interventions would be guided by the baby and not by the wishes of the parents. So the wishes of the parents would be that we would do everything, but everything would be us being present at the delivery and being guided by the baby. Does that make sense?
Yep, completely. I mean, obviously, the fact that we're going to try and give the baby a chance, help the baby resuscitate, doesn't necessarily mean that consigns us to doing everything if we think that that's not working. No. Also, I think the other message that I'm getting from you at the moment is the fact that we've started resuscitation, that we're helping this baby, obviously gives the parents time to spend with the baby, and we get more information to then be able to make decisions about whether we can continue and whether that's the right thing for this baby. Yeah. If we've kind of not had time to discuss that with the parents, or where the parents are kind of unsure, so if we have extremely preterm babies, obviously we do have a lower gestation below which, we don't resuscitate. And I'm going to be honest to say that, I haven't resuscitated babies under 22 weeks. And at this particular point, there's no evidence to say that is the case. But again, the outcomes for babies at 22 weeks is quite uncertain, in terms of UK population data and neurodevelopmental outcomes. So, we're at the start of a journey, which kind of means that parental choice is very important, and being, completely honest with the parents about outcomes where available is crucial. Lisa, what is the one thing from your perspective that you think in the 35 years that you've worked that parents most value? I mean, just in terms of, especially when you're in a situation where the baby doesn't make it. I mean, are there any kind of tips you have, any kind of golden, tips you have about what your feeling is with regards to what parents, really value?
What parents really value is honesty and empathy, I think, and being part of that decision-making process. I think what parents really want is for you to be honest, and sometimes being honest is really hard, because you're saying things that that are hard for them to hear and that you don't really want to have to say. But you're doing them a complete injustice if you're not honest with them. And I think and they want to feel part of their baby's care, and they want to know that you empathise with them, and that this isn't just another baby. This is their baby, and this is an individual baby and an individual situation in its own right. So, having worked in neonates for 35 years, I would want every parent to think that any baby that I looked after at end of life care was the most special baby that I've ever looked after, because that is what they will take from this. Lots of things that they won't remember, but what they will remember is extreme kindness and empathy, but they'll also remember the things that didn't go quite so well as well. There's quite a lot that they won't remember, but the extreme kindness and the extreme empathy, they absolutely will. So I think it's important that this isn't just another baby, that this baby is a special baby in its own right.
What's your advice to centres which, not necessarily in the UK, but other centres which are very high volume, where we don't have dedicated staff to be able to do this, where we're overwhelmed because of a lack of resources? It's so hard. What would your advice be to staff there, how do we look after parents in those settings? It must be so difficult for them. And is there anything
It
else
must
that?
be. I think it must be incredibly difficult. I can't even begin to put myself there because I've never experienced that. But all I would say is, even if you're very short staffed, or you don't have a lot of resources, the one resource you have, and it doesn't cost anything, is empathy and kindness.
That's
And I think that's what parents need. It's not all about all the bits and pieces that we can give them, and like things we do in the UK, like memory boxes and hand and footprints. It's the hand on the shoulder, it's the touch, it's the feeling that somebody really really cares, and that's what's most important. And I think you can deliver that in any setting.
Thank you so much, Lisa. That's been absolutely fantastic. I can't thank you enough for speaking to us today. Uh, I just gonna ask the audience if they have would anybody like to ask any questions live from the people who are interacting? I'm very happy for you to ask any questions if you'd like to. So we just got a few comments here to say thank you. That was very insightful. This is lovely. You've got she is so brilliant. We're gonna miss you. Okay. So it's just to say that Lisa's leaving us, obviously. Well, not leaving us. She's staying here and she's going to work with us at least one day a week. But again, I just want to take this opportunity to thank all the participants, both interacting live as well as on YouTube. And I'd like to thank Lisa for the session today. Thank you so much, Lisa.
You're welcome. I've really enjoyed it. Thank you, and good luck to you all wherever you are. Take care.